severity criteria documented a 12% parasitemia alongside his 7.0 hemoglobin and his profound multi-organ dysfunction.
Either way, any parasitemia over 10% is classified as massive hyperparasitemia. We must transition immediately to the emergency response.
Treatment for severe falciparum malaria with hyperparasitemia is an absolute medical emergency. This requires intensive care.
The first-line treatment protocol in the intensive care unit is the administration of intravenous artesunate. The weight-based dose is 2.4 milligrams per kilogram. It is administered immediately at 0 hours, then a second dose at 12 hours, and a third dose at 24 hours.
And during this critical window, the laboratory continues to play a vital monitoring role. Thick and thin blood smears must be repeated every 12 to 24 hours to visually confirm that the parasitemia is genuinely decreasing.
Right. And once the parasitemia successfully falls below 1% and the patient is clinically stable and able to tolerate oral intake, they transition off the IV medications. They're stepped down to a complete course of oral artemisinin-based combination therapy, or ACT, such as artemether lumefantrine, frequently known as Cortem.
Yes, the oral step-down is crucial.
So if I'm a clinical student observing this, once the parasite count drops below 1%, the fever breaks and they switch to the oral pills, the crisis is over, right?
Yeah.
The patient is fundamentally out of the woods.
That is a very dangerous assumption. Unfortunately, no. And this is a crucial insight for clinical management. The patient requires strict, ongoing monitoring for hidden, delayed complications. The war leaves a devastating aftermath.
What exactly are we monitoring for after the pathogen is seemingly defeated?
The most dangerous hidden complication is post-artesunate delayed hemolysis, or PADH.
PADH. So how does PADH happen? If the artesunate killed the parasite, why is there delayed hemolysis weeks later?
It comes down to how the spleen functions. The artesunate rapidly kills the parasite while it is still inside the red blood cell. As these dead parasite-containing red blood cells pass through the spleen's macrophages perform a process called pitting.
Pitting?
Yeah. They surgically pluck the dead parasite out of the red blood cell and then return the red blood cell back into the general circulation.
So the red blood cell survives, but it has essentially been chewed on by a macrophage.
Exactly. It is structurally compromised. Its lifespan is severely shortened. Between 7 and 30 days after the initial life-saving treatment, millions of these fragile, pitted red blood cells prematurely rupture all at once.
Meaning the patient's hemoglobin completely crashes again weeks after they have been discharged and think they are totally cured. That is terrifying.
Which is precisely why clinical guidelines mandate that hemoglobin levels must be strictly monitored weekly for 4 full weeks after treatment.
Wow. We also have to monitor for profound hypoglycemia, or dangerously low blood sugar, right?
Yes.